That was me in 2008 when I was invited in Madhya Pradesh. So I would like to interact with you about myopic traction maculopathy and a new staging system that I am proposing. So what do we know and what we don't know about myopic traction maculopathy? It is not one disease, but it is a spectrum of clinical pictures. There is no complete classification at the moment, nor consensus on the management. So the aims of my study were to first clarify all the types of MTM, and I'm going to ask you them at the end of the talk. Study the natural history of MTM, understand the pathogenesis, and propose the best management per each type. So in other words, let me say to unravel the secrets of MTM. Methods. The study was divided in different phases. The first one was a cross-sectional study. What did I do? My colleagues was proposing before me to review what we do, and that's what I did. I have reviewed 281 cases with MTM that I have operated since 2006. I have operated them with different types of surgery, and I first classified each one of them in type of MTM based on the preoperative OCT. So I have found 5 types of retinal patterns from the inner layers to the outer layers, and 3 types of foveal patterns. I will show you. So let's start from the inner layers. Inner schisis. Please look at the average age, 48 years of age, and the mean preoperative visual acuity is fairly good. Inner outer schisis, the average age is increasing. Predominantly outer schisis, the age is still increasing. Schisis with detachment, here the age is in line, not increasing. Pure detachment. Notice that when the detachment is complete, there is almost no schisis, and the age is increasing. So 5 types of retinal patterns. For each type, we might have different patterns in the fovea, 3 patterns. A normal fovea that I call type A, a lamellar macular hole, type B, and a full thickness macular hole, type C. So, associated finding could be epiretinal abnormalities or an outer lamellar hole. What is an outer lamellar hole? It is a splitting in the photoreceptors layer. So the average age is increasing with the different stages, and the difference is clinically significant from stage 1 to stage 5. In the second phase of the study, I have reviewed 72 eyes that could provide at least 3 OCT in time, never operated, so just to follow up the natural history with up to 11 years of evolution. And let's see some examples. Look at this male at 49 years of age. He has almost no signs of MTM, but he develops inner schisis, and then inner outer schisis, and then outer schisis, and then detachment. So from 2008 to 2017. Other example, from inner schisis to outer schisis. Another example, from inner schisis to detachment. See, 6 years. And other example, I have many. And I will offer you examples of tangential traction from inner lamellar hole to deep, almost full thickness lamellar hole. And this is another example, from lamellar hole to full thickness lamellar hole. So in the end, I propose the game of forces that act on the fovea. If we have one centripetal force that holds the retina together, against this force, many centrifugal forces might act. So a centrifugal posterior that detached the sclera from the retina, or the vitreous might pull the retina anteriorly, or the wall can pull tangentially, or the interface that pull tangentially but on the fovea. The forces can be combined, as in this case of retinal detachment with full thickness macular hole. So in conclusion, I think that MTM is divided not in types but in stages. I present you what I would like to call MTM Italian staging system, or MIS, because it's very easy to remember. So you have inner schisis, inner outer schisis, schisis detachment, and detachment. All of them with the normal fovea, or with the lamellar macular hole, or with the full thickness macular hole. So this could be one table that summarizes all the types. Each of them can develop to the right, to the bottom, or down right, and not the opposite. So from one stage, you know to which stage your patient could go. Let's do some example. I would like you to guess what you're looking at. So this is schisis detachment. It means type stage 4. The fovea is normal, type A, and there is an outer lamellar hole, so it will be 4AO. This is detachment, so it's stage 5. The fovea is normal, so it's 5A, and so on and so forth. Okay, but every classification has a meaning only if it tells you about prognosis and management. So I have calculated the mean time that takes to move from one stage to the other. And that's what I would like to propose. Do I still have some time? Am I out? I will move from the classification to the treatment. Just to tell you that I have studied, I will go to the treatment to know what to do with these patients. I have studied the tissue response to each type of surgical strategy per different stages. And basically, I wanted to find out the differences in result between macular buccal, pars plana vitrectomy, or combined technique. And I have seen from these patients that have at least 2 years follow-up, that there is a mathematical response to treatment. So the retinal patterns should be treated with the buccal, and the foveal pattern should be treated with the pars plana. I will only show you the final table, and then maybe if you want to have more information, you can come to me. I just submitted the results to the Retina Journal. I'm sorry, I don't have time to show you to show you all the slides. But the meaning of my slides was to tell you that if you use the right strategy for the right indication, you will reach the good result. If you do the opposite, you will have complication. So this is the final tables. In the first stages, you just observe your patient. If you have problems in the fovea, you should use pars plana and not buccal. If you have late stages with problems in the retina, you should buccal. And if you have problems in the retina and in the fovea, you should combine the technique. Thank you.